Sickle cell syndrome. It's a regressively inherited order of hemoglobin or a single point mutation in the beta globin chain where the glutamic acid is replaced with valine, okay? So the mutated hemoglobin acts normally but when it's dehydrated, deoxygenation or an acid environment, sickling occurs. So it can act normally except when it gets dehydrated or volume depleted, deoxygenated or acidic environment, sickling occurs. Sickling leads to vaso-occlusion and microvascular ischemia and hemolysis due to membrane. So this membrane, we don't think about the membrane of the red blood cell, how flexible it is to get into these small little capillaries and maneuver through these capillaries and get in and out of these capillaries. With the sickle cell, it becomes inflexible, so it's not flexible. It's like that old grandparent where they're not flexible and they just want to block everything. They block everything that you want to do because they're not flexible. That old relative that's blocking everything. Also, so why did this come about is because the sickled RBCs, they're less hospitable for malaria parasites. So this is a genetic mutation that carried forward. So hemoglobin S results in a polymerization during oxidation stress, causes formation to change to a sharp sickle. So just fancy way of saying, hey, this is changing to a sickle, resulting in obstruction in circulation. They're blocking things. They're inflexible. They're inflexible and they're blocking. You can have adhesions of these cells and decreased nitric oxide and vasoconstriction, causing worsening of symptoms. Most patients with homozygous sickle cell trait are African American, with 1 in 200 African Americans having the sickle cell trait. Sickle cell disease, continued discussion, avoid transfusion whenever possible. So each unit of blood transfused puts a patient at higher risk for developing autoantibodies to RBC antigens. We also need to watch for iron overload. Don't transfuse based off of numbers, but if the patient is symptomatic. But consider when less than five, yeah, that would definitely be, or 2 points less than the patient's baseline. So if less than 5, for sure you want to consider it, or 2 points less than baseline. So if they're sitting at 7, you want to consider at 5. But watch the way their symptoms are. And we can have a hyperhemolytic crisis, massive hemolysis caused by antibodies to the transfusion, RBC agents, and cause fatal acute anemia. So we'd follow what? The LDH, the AST, and indirect bilirubin. Also the hepcidin. All right, aplastic crisis is a stressor shuts down the bone marrow and hits RBC production. This can be a viral infection can do this. You can have a low reticulocyte count, normal reticulocyte count in sickle cell disease is around 80 to 20. All right, let's talk about simple versus exchange transfusion. We briefly discussed this. Simple transfusion, a unit of packed red blood cells, reduces the ratio of sickle to total hemoglobin. Exchange transfusion, we remove the patient's blood and replace it. Remove and replace it. With PRBCs, fast reduction in ratio of sickle to total hemoglobin, no increase in viscosity, because in the simple transfusion, we're going to increase viscosity used for acute end organ dysfunction. We have our examples, acute stress syndrome. All right, let's talk about sickle cell disease. Sickle cell disease can cause a chronic hemolytic anemia with maintenance counts depending on a brisk reticulocytosis, meaning are they able to replace those? This is vulnerable to infections. Parvo B19, and folate deficiencies. So Parvo B19, I want you to think about it can freeze the bone marrow. It freezes the bone marrow. And so we're already depending, we're having destruction, rapid destruction. And we're hoping that we get rapid reticulocytosis replacement. Sometimes that doesn't happen as well as it should. An example would be parvovirus B19, where it's going to freeze the bone marrow. We're going to have destruction, but not replacement. Consider prophylactic transfusions, but remember, we have to worry about autoantibody from the prior infusions. This can make it harder to replace the blood and can cause us poor problems in the future. Hydroxyurea therapy can be used if a patient has 2 or more vaso-occlusive episodes per year. We'll talk about what the side effects of that is. It decreases the episodes of acute chest pain chest syndrome and have a prolonged overall survival. What can hydroxyurea therapy, what are the side effects? Myelosuppression, neutropenia, thrombocytopenia, anemia, gastrointestinal side effects including nausea and vomiting, diarrhea, constipation, anorexia. It can also have dermatological reactions such as papillary rash, skin ulcerization, and cutaneous lupus. So a good medication has side effects. So let's talk about other things in sickle cell disease. Is pain can occur anywhere in the body because you're going to have obstruction. And an example would be, has you ever been out in extreme cold weather and you feel like your fingertips kind of that prickly feeling, and that's kind of like you having some ice crystals in your blood. That's kind of that same feeling, but on a bigger scale of when you have a sickle cell disease, when you have these vaso-occlusive crises. Like that limb is not getting the blood flow that it should. It can occur anywhere in the body, so you need to have pain treatment, usually requiring scheduled narcotics, and they can have chronic pain. We also have to worry about splenic infarcts, is that the spleen can be destroyed, and you can have infectious complications, especially for encapsulated organisms. An example would be salmonella, and that's why it's important that these patients get their vaccines. Acute sickle cell chest syndrome infiltrates with chest pain, dyspnea, and hypoxemia. Cannot tell the difference from pneumonia. This is in our example that we used for our young man. What's the treatment? Oxygen, broad spectrum antibiotics, IV fluids, pain control. Mild, when you're going to have a SpO2 of greater than 90 with a single lobar infiltrate. And you may need to give 0 to 2 units of RBC transfusion. Remember, we want to avoid as much as possible. Moderate, SpO2 less than 85, less than 2 lobes. You may need to give a 2 to 3 RBC transfusion or exchange transfusion. And severe, you're going to have the SpO2 less than 85 and greater than 2 lobes. This is where you consider a exchange transfusion. This is really where you can use some help. And this is one where you'd want to consider getting hematology on board. I know that you want to take care of things and you want to do great jobs for your patients, but sometimes we need help and an expert. This may be is we need to get hematology on board. Usually these are younger people and we want to get their lives better. Acute chest syndrome, continued occlusive involvement of the pulmonary vasculature and diagnosed by a new pulmonary infiltrates involving at least one component of the lung segment that is consistent with alveolar consolidation. Must have at least one of the following: chest pain, fever, tachypnea, wheezing, or cough. Increased risk for infection from encapsulated. We keep saying this: bacteria, elevated white blood count plus fever. Patients should be treated immediately for encapsulated infections. We're worried about pneumococcus. Instead of spirometry to reduce the risk of acute chest syndrome, that's when we're breathing out. We're breathing out instead of spirometry. Acute chest syndrome will have a lung infarction, concern for the eyes, brain, and penis. Consider exchange transfusion. This is where you dilute out the sickled hemoglobin with normal hemoglobin. Suppress EPO, increase in oxygen, hemoglobin oxygen saturation. This is the benefits of the exchange transfusion. All right, let's talk about cerebral vascular accident. So 30% of the hemoglobin SS patients, the sickle cell patients without overt stroke symptoms, can have silent infarcts. Transcranial Doppler of the middle cerebral artery shows strong predictor of stroke risk. Prophylactic transfusion or exchange transfusion and switching to hydroxyurea can be warranted. Strokes in the 3rd and 4th decade of life, and these patients are usually hemorrhagic in nature and attributable to underlying moyamoya disease. Moyamoya disease, and we'll talk about this, in the arterial narrowing at the basal ganglion cause fragile collateral circulation. Moyamoya disease is a chronic progressive cerebrovascular disorder characterized by stenosis or occlusion of the terminal portion of the internal carotid arteries. Where the term comes from, moyamoya refers to the angiographic appearance of these collaterals, which it resembles a puff of smoke, which in Japanese is moyamoya, puff of smoke, moyamoya. hepatic crisis, right upper quadrant pain and elevated ALFTs, and enlarged liver, and unusually sudden onset of self-limiting due to vaso-occlusion. So it's usually sudden onset and self-limiting due to vaso-occlusion. Transfusion or exchange transfusion is the treatment of choice to support symptomatic anemia. Always rule out other causes of the LFTs and enlarged liver. What if we have a sudden drop in hemoglobin? Can be folate deficiency. Here we go, parvovirus B19 freezes the bone marrow. The first thing that changes is the reticulocyte count. This is the urine of the kidney. The urine, remember, the urine is a first sign that you're having acute kidney injury, is that decreased urine output. The first thing you're going to see in sickle cell is going to be the huge drop in the reticulocyte count. The most accurate test is a PCR for DNA for checking for parvovirus B19. Treat IVIG. This can be serious. Treatment for sickle cell disease, hydroxyurea, increases level of hemoglobin F, reduces the rate of vaso-occlusive crisis, and reduces mortality. Increases MCV. Patients not taking, if they say they're taking it, but they have a normal or low MCV, they may not be taking it. Volexer binds hemoglobin and reduces sickle cell hemoglobin polymerization, increases hemoglobin levels, but does not reduce the rate of vaso-occlusive crisis. Crizizumab is a P-selective inhibitor which blocks the adhesion of white cells and platelets, reduces vaso-occlusive crisis. And L-glutamate is an antioxidant, reduces rate of vaso-occlusive crisis. How do you know if you're getting enough hydroxyurea? So the hemoglobin F, the fetal hemoglobin level, increases, it dilutes out the sickle cell hemoglobin. Once it gets to 10 to 15% hemoglobin F, it does not sickle as much. How do you know if you're getting too much hydroxyurea? Is when you have drops in the white blood count, because it is marotoxic. CVA for sickle cell disease can be a vaso-occlusive clogging due to high concentrations of hemoglobin S. Exchange transfusions to rapidly reduce the hemoglobin levels. Chronic simple transfusion therapy may be warranted every 4 to 6 weeks with a goal of hemoglobin S levels less than 30. Now imagine if you're constantly doing these transfusions, all the autoantibody types you're going to be building up. You need to make sure that you're monitoring for iron overload and may need periodic chelation, prevents hepatic fibrosis and cirrhosis. All right, what if a sickle cell patient has sudden hip pain? What can this be? Is aseptic necrosis. The cells in the bone marrow die. So we can have aseptic necrosis of the hip. Blood product compatibility. So AB plasma, patients who have AB positive plasma can transfuse in anyone because it contains no hemagglutinin. Now, so what would be the prize patient would be an AB positive male, okay? So an AB positive female, if she has pregnancies and pregnancies with different partners, she can have hemagglutinin in there from those partners, okay? So AB positive males would be the best source for plasma because it can be transferred anywhere. O negative RBCs can be transfused to anyone because there are no A plus and B antigens. Remember, negative type O is considered the universal donor for RBC transfusion. It lacks A, B, and RH antigens. Negative ORBCs can be given to any ABO and RH type in emergencies. For routine praxis, you need to match the ABOs. Now, there can be rare cases where patients have had multiple transfusions, and they've had so many where they have autoantibody types that they cannot even get the O negative. It's rare, but you do come across it. Type AB positive individuals are universal recipients for RBCs as they lack anti-A and anti-B and anti-RH and negative RH antibodies. They can receive RBCs from any ABO and RH type. Type A individuals can receive RBCs from type A and type O donors. Type B individuals can receive from type B and type O owners, and both must match the RH status if possible. So remember, type AB positive AB individuals can receive ABO from all types, but it's preferred to have a match with the RH type. Blood product compatibility, continued discussion. O negative universal donors, as we discussed, but only should be given in emergency situations if type and cross match cannot be done in time. 1 unit of packed red blood cells is about 250 to 300 milliliters. It's not a perfect product because this is coming from humans. This is not a manufactured product. It increases hemoglobin roughly 1 gram per deciliter in the absence of bleeding, destruction, or sequestration. This is not perfect because this is coming from one individual to another, so it's not a perfect process. It doesn't always get to 1 gram. And you can go through the blood literature and they'll discuss it. It's not perfect. Most places will have universal leukoreduction policies for the blood bank. Leukoreduction eliminates the inflammatory response to red blood cell transfusion in humans. Leukoreduction has been shown to lower the incidence of virus transmission. They're getting rid of the leukocytes, autoimmunization, immunosuppression, and inflammations, which contribute to the morbidity and mortality. Goal is when we're transfusing blood products, the whole goal is, remember, we go back to that lecture about perfusion. We want to improve oxygen delivery to the organs. We want to improve our perfusion. Transfusion indications for RBCs, acute blood loss, anemia with hemodynamic compromise, in hospitalized patients without symptoms and end organ damage transfuse only if the hemoglobin is less than 7. Platelets, active bleeding with platelet counts less than 50 to 100,000. Active bleeding with dysfunctional platelets, why would they be dysfunctional? Well, just think about it. What's the medications that we talked about in our cardiology lecture? We're going back to the cardiology lecture. Well, we talked about the P2Y12 inhibitors. We had our prasugrel, we have our clopidogrel, and we have our ticagrelor. Those are going to cause us to have dysfunctional platelets. Transfusion indications continued. Prophylaxis is if we have platelet count less than 10,000, may want to consider, even without an active bleed. Platelet count less than 50,000 in planned surgery, and 100,000 in planned intracranial surgery. Let's talk about the transfusion triggers. Now, all these kind of studies originate back into the TRIC study, the transfusion and transfusion requirements in critical care. This was done in 1999. This was a group of hospitals and providers in the acute care environment on transfusions, and these hospitals got together and they did a nice collaboration. It was so great is that this affected the medicine world as a whole. These people and individuals and hospitals in New Zealand were able to get together and affect the whole world. And why is excess blood transfusions? What is the problem? What causes this? We think more blood, better, right? Well, there's a risk of increasing portal hypertension and then increased risk of rebleeding from the excess amount of blood. Also, we're still learning is that there may be local cytokine changes and inflammatory responses because remember, you're not getting your blood, you're getting someone else's blood, even though they do such an amazing job of matching, but there may be a sub-level of matching that we're just not understanding yet. So let's go to the MINT trial in 2024. So we're gonna see a lot of data now on do we need to have a liberal transfusion or restrictive transfusion in patients who have an acute MI. Now the restrictive strategy of 7.8 versus 10 grams. Let's go back to that real quick. So the results were, the risk of cardiac death was significantly higher in the restrictive versus the liver group. So restrictive was 5.5, that's a 7 and 8 versus 3.2. 5 times more patients discontinued the protocol in the liberal group was due to, and so this can be where this trial is thrown off. So patients with type 1 MI may have had more benefit. So this has included all types of MIs. So patients with type 1 MI may have had more benefit. So we still don't know, but in the guidelines and the cardiology guidelines still have, they have more of a liberal transfusion, but the data isn't great. We have different studies going back and forth. This is something to be continued, and we need to balance the factors of the volume overload and transfusion reaction, and may still need to be an individual patient decision until we can get more data.